Welcome to the CMEessentials audiocast, covering current topics in clinical medicine. The show helps clinicians stay up to date on the current standards of care and catch up with the latest clinical developments and trends. Each episode features a lively discussion between the physician host and a noted clinical expert. They dig into the issues practitioners face every day and provide insight on improving patient care.
Hello, and welcome to the latest installment of Oakstone's CMEessentials in Internal Medicine. I'm your host, Dr. Gabby Berger. I am an internal medicine, primary care physician, and clinical associate professor of medicine at the University of Washington. I look forward to spending time with you on today's topic, which, it's safe to say, is one that primary care clinicians deal with daily. Obesity is a major public health threat. Nearly 1/3 of adults in the U.S. meet the criteria for obesity. And now, it's becoming even more widely discussed with the availability of medications to assist with weight loss. We are delighted to have two obesity medicine experts help us sort through recent developments and suggest strategies to use in practice. In this first part of the program, I am joined by Dr. Fatima Cody Stanford, an obesity medicine physician scientist and associate professor of medicine and pediatrics at Harvard Medical School. Dr. Stanford, welcome.
Thank you so much for having me. It's a delight to be here with you.
Thank you. Our discussion is presented in two parts. In this episode, Dr. Stanford and I will lay out the scope of obesity in the U.S., redefine obesity through an equity lens, and talk about the new GLP-1 agonists, how they work, when to use them, and weight loss parameters to follow when considering them. In the next episode, I will bring in Dr. Scott Hagan, my colleague here at the University of Washington. We will address the problem of weight stigma and its impact on our patients, work through the challenge of prescribing in the face of heavy direct-to-consumer pharmaceutical marketing, and get Dr. Hagan's tips for using GLP-1 agonists and other anti-obesity medications. Let's start by outlining the scope of the obesity problem in the U.S. and provide a primer to anti-obesity medications. As we know, obesity is associated with poorer cardiovascular outcomes and metabolic disease, and linked with increased mortality. Development of obesity is multifactorial and depends on a complex interplay between genetics, neural pathways, dietary patterns, physical activity, and medications, among other factors. In general, all anti-obesity medications stimulate weight loss, improve metabolic parameters, and demonstrate significant benefits for cardiovascular outcomes, with up to a 20% reduction in fatal and non-fatal myocardial infarctions. Anti-obesity medications are indicated for a BMI greater than 30 or a BMI greater than 27 with one or more comorbidities, and a list of those comorbidities will be provided in our show notes. These drugs have variable potency and side effects. The choice of drugs should be based on individual patient needs and comorbidities. 7 medications are currently approved for weight loss. We will spend most of our time on the newer medications that have exploded into the public consciousness, highlighting what primary care providers need to know about efficacy, side effects, and affordability. But first, we will start in conversation with Dr. Stanford, who is widely known for her efforts to redefine obesity through an equity lens, in addition to substantive work understanding the complex neural pathways that control hunger and weight. Dr. Stanford, clinicians have traditionally used BMI to define weight categories and obesity, but we are learning that using BMI alone can be problematic. Help us understand why this is an inadequate method for addressing obesity.
Absolutely. So I think we need to go to our historical understanding of where BMI was derived. And so I want to take you back to the 1800s, where we look at Adolphe Quetelet or Quetelet, depending upon how you want to pronounce it, and look at this Belgian statistician who sought to define BMI or the Quetelet index as he looked at Belgian soldiers at the time. And that was a proxy by which he sought to decide, hey, what is normal for Belgian soldiers in terms of their weight status? This became the basis for eugenics, which Adolf Hitler used to determine what was considered normal for that time and the basis for, unfortunately, discrimination at the time. Now, I want to take us to the 1930s and 1940s, where the Metropolitan Life Insurance Company sought to discern what was considered to be your risk for dying based upon weight status. And at that time, they were looking at primarily white men and women and insurability. And so this term morbid, which I don't like as a modifier for weight status, came into being. They used actuarial tables to determine what was your risk of dying based upon high weight status if you're a white man or woman insured by the Metropolitan Life Insurance Company, hence the term morbid as a modifier or an adjective to describe obesity. And then let's take you all the way to the 1970s, which is a great decade, by the way. And this is where we started to see this idea specifically of BMI. And then we have keys that said, well, this is pretty simple. Let's just look at height and weight and put these together, and let's make it very simple across the population and determine what is considered normal. We haven't heard medicine play a role in any of this. And so when we look at BMI as a solo metric, we aren't looking at the health status of an individual. And so this is really important when we give someone a simple metric, just BMI alone, and tell them they need to meet this metric without looking at the overall health of an individual.
I so appreciate that historical perspective, Dr. Stanford, and it really brings me back to my own clinic when I think about the patients I see sitting in front of me and how we apply these broad population-based health metrics to individuals in our clinic and how oftentimes there's just a significant mismatch. I'm curious to extend this conversation. We know that obesity disproportionately affects racial and ethnic minority communities. And specifically, how does BMI fail to capture the range of experiences of minority individuals?
Well, this is a lovely conversation to have. And, I'm going to really talk from my perspective of being a non-Hispanic Black individual, descendant of the enslaved populations here in the U.S. And I'm going to talk about some of the unique experiences that we have that predispose us to having a higher level of adiposity. And what do I mean by that? Accumulation of fat mass. And why do we see disproportionate levels, particularly in our populations? So I want to talk about one of the key things that leads to a higher accumulation of adiposity, and that is stress, trauma, adverse experiences. And so when we are dealing with these populations that I happen to belong to, what we do know is that as stress levels go up, accumulation of adiposity goes up. So the more hits of stress and adverse experiences that one has, we expect there to be accumulation of stress and adiposity within that group that one is belonging to. So if we express this across different racial and ethnic minority communities here in the U.S., and we look at the Latin population, if we look at indigenous populations, and we experience stress within those populations, it's no surprise that we would have higher levels of overweight and obesity within these populations. And so it's important for us to recognize those as we think about what has been that chronic generational stress and trauma within those key populations, one that I happen to belong to, and what brought me to this work really to begin with.
I so appreciate you grounding our conversation today in these concepts of stress and generational trauma, because it's a perfect segue really to the next part of our conversation. We know that stress and trauma significantly impacts individuals. And you have talked about how obesity is not just about our bodies, but it's really a brain disease. And that is that our brain really dictates how much weight the body can gain or lose around a certain set point or set range. So I'm curious, for your patients in clinic, how do you counsel them on approaching weight loss when they're fighting against their own internal set range for weight?
So I think this is a really, really great conversation. And what I really like for my patients to do before they even begin this conversation with me about addressing weight and weight dysregulation is first I have them actually watch one of my old lectures. It's called Obesity, It's More Complex Than You Think. And this was a Radcliffe lecture that I recorded, I think it was back in either 2017 or 2018. And the reason why I have them watch this is because I want them to come into this visit informed about what that first initial hour, yes, I spent an hour with them on their first obesity medicine visit, is going to be about. I want them to deconstruct all of those notions about who they are, their value, their worth structure of who they are if they happen to carry excess weight, which they are if they're coming in to see me in obesity medicine. The reason why I do that is because they have already placed upon themselves some type of value structure surrounding what their battle has been with that weight range set point that they've been dealing with often for quite some time before they finally make it into that visit to see me. Maybe it's been going on for just a few years. Maybe it's been going on for 50 years. So I say, look, this is not your fault. I am here to help you deal with how your brain is addressing your weight. I may need to use some tools. And those tools may be under the umbrella of lifestyle and behavioral strategies. Those tools may be under the umbrella of anti-obesity medication. Maybe they are under the umbrella of metabolic and bariatric surgery. But I want us to find out which tools you would like to utilize. I'll tell you what I think might be the tools, but this is shared decision making. We're going to come together. Now, initially, you might not agree with me, and that's fine. You will likely agree with me after some time, but we need to come together. This is your body. You live in your body each day. I live in my body, but I want you to understand that this is going to be a long-term process. Most of my patients have been with me for 10 plus years. Why? Obesity is a chronic, relapsing, remitting disease. We don't typically hear that language. Relapsing, remitting disease. It doesn't just go away. It's not a magical treatment. Even in the midst of this explosion of focus on these new therapies that show tremendous promise, it is a chronic, relapsing, remitting disease, typically around this idea that the brain is always pulling us back to where it wants to be. And so when I define this thought process at the outset, it sets them up for this idea that we are part of a team. But the most important part that I have to tell them is that they are the team lead. I'm the coach, but they're the star player. And if the star player doesn't show up, I can't do my work, right? I am the coach, but the star player has to be there. And so they have to be willing and ready to engage.
I am absolutely loving this conversation. I'm going to just start by acknowledging that probably most of our primary care physician audience is just incredibly jealous of that 1 hour new patient visit time that you get with your patients. Always makes me question my career choices, although I do love primary care to its core. And I really, really appreciate your framing for us this idea of obesity is a chronic, relapsing, and remitting disease. And I personally have not heard this framing before, and it makes so much sense. It resonates deeply. And certainly, I think for us as primary care doctors, this is what we're here for our patients, to help manage these chronic diseases. And this is a really powerful way for us to think about partnering with our patients and shared decision-making over the long term. Also, obesity, it's more complex than you think. I hope that's available for all of us to access at some point.
It's freely available. It's not behind a paywall. I'll make sure that you guys have access. I think it's been watched a little over 80,000 times. And that you can feel free to share that widely with your patients or whomever would like to see it.
I think we'll link to that in our show notes because I think it'll be particularly helpful for our primary care physician audience as well. Getting back to what you were describing around the BMI as not being grounded in health, but in all of these other statistics, and really helping us back up and redefine obesity as a disease process based in biology. So Dr. Stanford, before moving on, we were just talking about how primary care physicians often don't have a full hour with our patients. And I'm curious if there are 2 or 3 key points that you like to bring up with patients in a shorter time or a shorter visit that help get them into the mindset of this chronic, relapsing, remitting disease and the need to really show up and partner together.
Well, first, I would say the number one thing is find out, are they ready to make a change? If they're not ready to make a change, this is a moot conversation. You don't even need to go down the pathway of even addressing anything. So in primary care, you have like 10 to 15 minutes. You don't have time to address it. If they're not ready to make a change, this isn't the time to have that conversation. So number one, readiness to make a change, discern that. Number two, find out what strategies are of interest to them. Like what are they interested in? Is it lifestyle behavioral? Is it pharmacotherapy? Is it metabolic research? So just kind of understand like what is the milieu of what they're willing to consider. And then I would say number three, have an understanding once you know what those things are, then you can decide like how many visits you're going to need to accomplish that, right? If you only have 10 to 15 minutes, you're not going to be able to accomplish that in one visit. You're going to need to schedule a series of visits. If it's lifestyle and behavioral, then you might need to refer out to some registered dietitians. Maybe you need to refer out to a tertiary level center if you're going to be considering metabolic and bariatric surgery. And then if it's anti-obesity medications, maybe that's within your wheelhouse. So just really understanding where they are within this pathway, that gets you an understanding of where you need to go in terms of what is your next step. But then you need to have those few questions answered so you know where to go.
Fantastic. I really appreciate that guide. And a perfect segue to thinking a little bit more about anti-obesity medications. You know, by now, most clinicians and people across America are familiar with the weight loss effects of GLP-1 agonists, specifically semaglutide. Now, one brand of semaglutide, Ozempic, is FDA approved for treating diabetes, and a second brand, Wegovy, is approved for weight loss. So, Dr. Stanford, can you remind us how GLP-1 medications work and why they are so effective for weight loss?
Absolutely. So this is really a key consideration. And here we're going to go back to the brain. So the key mechanism of how these medications work is we have to understand how the brain regulates weight. There are two key pathways in the brain that regulate weight. And there is one pathway that's called the POMC, or the pro-opiomelanocortin pathway. That's our anorexigenic pathway in the brain. That's the pathway that tells us to eat less and store less. So the GLP-1s upregulate that pathway of the brain, the pathway that tells us to eat less and store less. While it's doing that, it's also down-regulating the AGRP, or the agouti-related peptide pathway. That's the pathway that tells us to eat more and store more. So the reason why the GLP-1s are so effective is that they're working in the hypothalamus to do this work. Now that's the primary mechanism of actions, but it also does a few other things. It also slows movement through the GI tract. So when you go to eat, and if things are moving through your GI tract very slowly, you can imagine you feel full for longer periods of time because you're like, wait a minute, I ate breakfast a long time ago. I'm still full. It's almost dinner time. Things are moving through the GI tract slowly. It increases insulin and decreases glucagon secretion, and it also can affect adipose. It can increase thermogenesis within the body. So these are the key ways that GLP-1 agonists act within the body.
Now, in November of 2023, another drug joined the party when the FDA approved Tirzepatide for chronic weight management under the brand Zepbound, and it's also available under the brand Mounjaro, approved for treating diabetes. Now, when should a primary care provider reach for semaglutide versus Tirzepatide, or vice versa?
Excellent question. So when we're looking at semaglutide, on average, we're getting about 14 to 15% total body weight loss. This additional medication is a dual agonist. It's a combination of a GLP-1 and a GIP. What is a GIP? That's a glucose insulinotropic polypeptide. So it's a dual agonist, accounting for about 22.5% total body weight loss. So a much higher degree of body weight loss. With that higher degree of body weight loss is not just the weight loss that we're getting, we're also getting better blood glucose control, higher resolution and total adipose, which, let's say if you're carrying more weight in that midsection, we're going to have a greater reduction there, improvement in liver function tests, et cetera, et cetera. So if you have someone that has more problematic glucose control, worsened diabetes, et cetera, higher total body weight loss, that might be the person that you need to reach for that more aggressive agent, right? A dual agonist, a GLP-1, GIP combined into one agent, that would be the patient that you would consider that for.
Now, we often hear about the side effects of the GLP-1 agonists, including nausea, vomiting, and abdominal discomfort. In your practice, how common are these side effects, and do you find them to be dose limiting for your patients?
No, and not necessarily. Now, let's talk about how common they are. The most common out of the things you just mentioned is nausea. So about 40 to 45% of patients will experience nausea as they move up the dose titration. I'll focus on the dose titration for semaglutide and for Tirzepatide, which are the two drugs that we'll talk about. And we'll talk about just the dosing. So for semaglutide, we have 0.25, 0.5, 1, 1.7, and 2.4 milligram dosing. And the earliest we're supposed to increase that dose is at a 1 month interval, okay? That's the least amount of time. Notice I'm saying the least amount of time. And if we follow the package insert, it says to increase it every month. But I want to say something as a caveat to that, particularly with the primary care clinician listening. Notice I said the least amount of time. If a patient is still experiencing nausea, going from 0.25 to 0.5, does it make sense to double the dose? I want you to think about that logically. No, it doesn't make sense to double the dose at a month. Maybe that patient needs additional time at 0.25. Maybe they need 2 months. Maybe they need 3 months. Maybe they need 4 months. So it's really important as the clinician, as the primary care physician, to listen to the patient. The trials have shown 20% reduction in major adverse coronary events from semaglutide. The 5-year data is out. We know that. We've seen a reduction in fatal and non-fatal myocardial infarctions. We've seen reduction in stroke. We know the data is there. So if we know that, we are getting benefit, right? So if we know this and the patients are doing well and we can mitigate the side effects, let's slow down the titration, okay? Tirzepatide dosing, 2.5, 5, 7.5, 10, 12.5, 15, that's the dosing. Minimum month. If you're having side effects, slow down.
Now, Dr. Stanford, I want to turn to a Perspectives article that you recently co-authored in JAMA Internal Medicine, in which you describe potential adverse health effects of these medications beyond the common side effects of GI distress. And I found this to be really provocative as a primary care physician. Can you tell us more about your concerns in this domain?
Absolutely. So we are talking about body composition now. We're talking about lean muscle loss. So I recently published with 2 of my mentees at Stanford, but we talked about body composition. And so when we're looking at particularly a lot of the benefits from semaglutide, tirzepatide, any of the GLP-1s, we're getting our greatest benefits in older adults, right? And during this time, we're also talking about loss of lean muscle, which we're going to really start to see as we age, right? Particularly as we go from middle adulthood to older adulthood. So we're getting into this realm of our geriatric colleagues, and they're concerned about, can you do things like get up and go, right? These are things that we're thinking about. Now, one of the things that the FDA has been very keen upon is measuring fat loss. I've been able to rattle off numbers saying 15% total body weight loss with semaglutide, 22.5 with tirzepatide. If we look at the triple agonists coming down the pike from Lilly, 24.5, et cetera, the numbers are going to keep getting higher. But we aren't adequately measuring what is lean muscle loss. We know that we're going to lose lean muscle. We need to be measuring this. We should be holding pharma accountable for this. You know, everybody's like, oh, well, Dr. Stanford's paid by pharma. Yes, I am. That is true. But I also want them to tell me this, right? We're seeing weight loss and we're losing lean muscle while we're also losing fat. How much of it is lean muscle? We don't want to lose that. That's favorable to the body. And so this is what my perspective was in JAMA IM, specifically on holding pharma accountable for also measuring this as they're doing their large-scale trials here in the U.S. and abroad.
That is fantastic. I appreciate that important perspective. And I'm curious, in this article, you suggest focusing more on fat loss, potentially rather than weight loss, and that this may be a safer primary endpoint for these medications. Can you tell us more about what metrics you feel clinicians should be using to measure progress?
So this is an interesting caveat here, because I talk about it would be nice for us to discern fat loss. The problem is that we don't always have on the ground the tools by which to measure fat loss. There is a study that I published where we used visual-based capture as I was validating a tool where we were able to discern fat loss with visual-based capture about the accuracy that we are able to do with DEXA. That was commonly available in Amazon's Halo device. DEXA is several thousands of dollars. I can't just give that to every person to do all the time, and the time that has to go into doing a DEXA study. I mean, that's very laborious. I mean, obviously we do it when we're looking at bone quality, evaluating for osteopenia and osteoporosis, but it's not really scalable on the population. It's not very equitable, right? We talk about equity. So when we're looking at fat loss, we can do other things of looking at like waist circumference. We can compare that with or at that to weight and other metrics to kind of get a sense of what body mass is going on, and we can use bioimpedance. Bioimpedance has some issues, but we do need kind of better metrics. And I think visual-based capture, if it could be expanded to the population like has been validated, would be great for us really getting a sense of fat loss.
Fantastic. I think that really helps us think about what is in our future, what might be on the horizon as alternatives to simply using the BMI and other conventional metrics for measuring weight loss. I'm curious, just two last questions for you today. The first is really, what parameters do you use to help your patients set their personal weight loss goals? You've talked a lot about collaborative shared decision-making and the challenges with using the BMI alone. So curious to hear a little bit more about how you counsel your patients.
Well, so I never let my patients, well, I'm sure they do in their brains, but I never give them a weight target. So they will often try to say, well, I, have my target weight. And I'm like, I'm not listening to you. I will kind of do something like a little kid would do and kind of do, I'm not listening. And the reason why I do that is because I think weight goals are really arbitrary. I do, however, have health goals. And what do I mean? I do allow them to have a target waist circumference because that gives us a proxy by knowing what their metabolic health risks are. Let's look at what is their target cholesterol values, their target blood pressure. What about their liver function tests? What about their fasting glucose? What about their insulin level? We do have target metrics there. Once all of those things are aligned and the weight is in order, then we're really excited. Those are the things that I'm looking for, and those are the things I'm championing with them.
Such a much more holistic way of looking at health than simply looking at one number like overall weight or BMI. So, Dr. Stanford, a final question for you, and I'm sure many of our listeners are curious about. You've discussed not prescribing GLP-1s solely for aesthetic weight loss, which is certainly something we have heard about enormously in the media over the last year and more. So, how do you draw the line as a physician?
You can't get through to me without having true metabolic health dysfunction. So, I think this will probably fall more in the realm of what the primary care physician would have, whether it's internal medicine or family medicine. You might have a higher likelihood of seeing someone that is coming in solely seeking, an GLP-1 or some other type of medication for aesthetic reasons. Obviously, we've all seen the major shortages that exist with regards to these agents. They've been dire, to say the least. And this is not just an issue here in the US. I spent time on a call today with the World Health Organization as we talked about what the access is worldwide. These are pervasive. I think we need to be thoughtful about who really needs these agents and make sure that the people that actually need them can get them. And even then, we recognize that even those people aren't able to get access due to the supply chain access, affordability, and the list goes on.
Thank you so much for reminding us that obesity is really about metabolic health dysfunction, and that should be our parameter and our North Star as we think about prescribing these medications moving forward. Dr. Stanford, thank you so much for sharing your deep knowledge and expertise with our listeners. It has been an absolute pleasure to speak with you today.
Thanks so much for having me. It's been a delight being with you.
Let's close this episode by summarizing key take-home points from Dr. Stanford in the literature. First, traditional definitions of obesity, specifically the BMI, do not capture the range of experiences of racial and ethnic minorities who struggle with weight, especially because the calculation cannot distinguish between fat and muscle. Soon, physicians will likely see alternatives to diagnosing obesity, including the waist circumference and DEXA scanning to determine the amount of fat tissue present. Next, GLP-1 agonists work by altering neural pathways in the brain that direct the body to eat and store less. Patients may lose up to 15% of their body weight with Semaglutide, or Ozempic and Wegovy, and up to 22.5% with Tirzepatide, or Mounjaro and Zepbound. It's important to remind patients that they should increase the dose slowly and according to manufacturer recommendations to reduce the risk of GI side effects. Finally, physicians must be attentive to the impact of medically assisted weight loss on other aspects of our patients' health, including a decline in bone density, loss of muscle mass, and an increased risk for frailty, particularly among older individuals.
The opinions expressed are those of the reviewers, authors, and commentators and do not necessarily represent the views of Oakstone Publishing. Please review the complete prescribing information of specific drugs or combinations of drugs including indications, contraindications, warnings, and adverse effects before administering pharmacologic therapy. Thanks for listening to CME Essentials in Internal and Family Medicine. To learn more, visit oakstone.com.